they said, yeah, you need a heart pretty much immediately. And that was a big shock.
A years-long journey to save his failing heart. Today, you'll meet a man who went from patient to survivor. Plus, now has a new mission, all thanks to his organ donor. Good morning, I'm Jessica Lovell, and welcome to the Morning Medical Update. Organ donation is a selfless gift. Right now, Donate Life America found there are around 4,000 people in the U.S. waiting for a new heart. Some end up waiting more than a year. For Brian Pitts, though, he is here today thanks to an organ donor. He is just 3 days away from celebrating a huge milestone, 1 year with his new heart.
All eyes are supposed to be on the bride during a wedding, but the attention quickly turned to one guest, Brian Pitts, when he suffered a heart attack. Lucky for him, the bride happened to be a registered nurse who performed CPR until paramedics arrived.
And I woke up the next day not knowing anything that had happened. And they said, you've got hypertrophic cardiomyopathy. It was something I was born with. It's a congenital defect.
That was 2007. Doctors implanted a pacemaker defibrillator. And for years, he met with his University of Kansas Health System cardiologist, Dr. Lauren Barenbaum. 4 years later, Brian's life would be saved a second time when that defibrillator worked exactly as it was supposed to work.
And got kind of woozy, dizzy, leaned on the counter, and boom, the thing shocked me. And it doesn't feel good, I'll tell you that. It is literally shocking from the inside out.
10 years later, in 2021, it happened again.
I got down to my knees in the living room and I shouted for my wife, and sure enough, the thing hit me.
But after this event, doctors gave him another jolt with the news that Brian was in heart failure. He needed a transplant.
Started to do more testing and really looking at what's going on with the heart. And indeed, he confirmed that I'm in heart failure from hypertrophy and I need a heart. Hearing that was pretty shocking.
Then Brian got COVID.
And I am horribly sick. My heart's doing weird things.
He recovered and made it onto the transplant list.
I was listed for 63 days until I received my new heart. I woke up pretty quickly after surgery. I think I was awake about 5 hours after surgery.
His gratitude now powers him on a new mission.
I think everybody in America should be a registered organ donor. It's that important.
So important, he's even put Donate Life messages on his Jeep.
And now I drive around town as the Donate Life guy.
Brian also mentors fellow patients who are preparing for heart transplants. He also serves as a volunteer ambassador for the Midwest Transplant Network.
Having been through it and having to come to terms with it, I think I'm able to more easily console these people for what's going on in their life.
A patient, a survivor, and now an advocate.
And the Donate Life guy is with us this morning. Brian, good morning. How are you?
Hi there. Good morning.
What a journey and what a story. Can't wait to hear more about this and how you're doing now. Here in studio, we have Dr. Hirik Shah. He's a cardiologist specializing in heart failure and transplants. How are you?
Good. Thanks for having me.
Good to see you as
Brian,
always.
Good to see you.
Yes.
Glad you're doing very well.
Good reunion. We will also learn more about organ donation from Nicole Asquith from the Midwest Transplant Network and how it all works together. Good to see you as well.
Good morning. Thank you. Hi, Brian.
Hi, how you doing?
You know each other well.
We do.
You do. He does a lot of good stuff. So, Brian, let's start with you. So you've had heart trouble since your late 20s. You've needed different medications and a defibrillator implant. How do you feel today after all of that, now having a new heart? How's it going?
After transplant, I'd say around 6 months, I started to feel some of the fatigue lift, getting used to a lot of the medications. Around 8 months, I really started to feel pretty great, able to do a lot of activities that I used to do. And now here at almost a year, I'm back doing pretty much everything I used to do. I've remodeled a bathroom recently. I'm working a lot outdoors in the garden, preparing for the growing season and doing projects around the house. And pretty much without fatigue, without any issue, and that's pretty fantastic.
You both all good with that? All this activity he's doing, good for him, right?
Yes. Do more. I love it.
Remodel
yes.
the whole house.
Yes.
Plant away. Any complications so far? Anything at all, even in the early days?
Yeah, in the very beginning, we had a couple of bouts of rejection. I came back from a biopsy my first time as an R2, which was mild rejection, and we treated that medically, just increasing some medications. And a few months later, I think about 6 months out, I came back R2 again. And we did a little infusion. I spent a couple of days in the hospital, and that went away. And since then, I keep coming back as an R0 every time. And in a year, I'll have my my next biopsy for my right and left heart. I think next week, and hopefully everything looks great.
And is that pretty typical? We're going to talk more about what those numbers mean, but pretty typical to have to come back as you're monitoring these patients post-transplant?
Yeah, we monitor patients very closely for heart transplant rejection. It's one of those things that does happen. It doesn't happen in everyone, but it's one of those things that we serially assess for all of our patients with routine biopsies and blood tests. And Mr. Pitts, Brian, had some episodes of grade 2R rejection, which, like he said, was mild. And we're very aggressive in treating that, so because we don't want that heart to have any significant damage. And he responded well to the therapy. And after we got that second bout kind of under control, I think he's been kind of flying with, passing with flying colors since. So I think that biopsy, your yearly testing, I'm going to assume is going to be very good. And keep doing what you're doing.
So let's talk about hypertrophic cardiomyopathy. Exactly what is that?
Yeah, that's a great question. So hypertrophic cardiomyopathy is actually the most common genetic condition in the heart. It actually affects around 1 in 500 people, and maybe even more as we are learning more about the diagnosis and are having better tools to diagnose these patients. And what essentially it is again, it's a genetic cardiomyopathy. People are born with this, and it causes abnormal thickening of the heart called left ventricular hypertrophy. And with that can lead to a various amount of symptoms. Most of it causes decrease of blood flow from the heart to the rest of the body. So these patients can have chest pain, they can have shortness of breath, they can have lower extremity swelling, basically have symptoms of heart failure. But on the second part of that is that a lot of patients can have what we call arrhythmias. The hearts are genetically abnormal, and so they are at high risk for what we call ventricular arrhythmias, where your heart goes all of a sudden very, very fast. That's exactly what Mr. Pitts had. He had ventricular tachycardia, and it's one of those risk factors for sudden cardiac death. When you hear about these young athletes who might be at sporting events and they all of a sudden collapse and have to have CPR, one of the most common reason for that is hypertrophic cardiomyopathy. So it causes, decrease in the heart to pump blood to the rest of the organs, but then also some patients are at high risk for ventricular arrhythmias, and so sudden cardiac death is one of those things that we will look for very carefully.
So how often does this disease end up requiring a heart transplant? Is there any way to get ahead of it?
Yeah. Thankfully, not very often. On most published series, around 3 to 5% of patients will end up requiring a heart transplantation. If you look at hypertrophic cardiomyopathy as a total population, the life expectancy is actually very similar to the average population. But they are at risk for certain conditions like I talked about, so those patients need to see cardiologists very often, get serial echocardiograms, get monitors on their heart, because some do progress to a point, like Mr. Pitts, where they might end up needing a heart transplantation. So they just have to be watched, in clinic very carefully. But all in all, the survival is actually pretty similar to the average population.
Well, that's good news. I want to see those echocardiograms. We brought some. Kind of tell us what we're seeing here.
Yeah, so this first echocardiogram is of a normal heart, and again, don't expect everyone to exactly know what this is supposed to look like, but that bottom chamber that's kind of beating, that's a left ventricle. And that's where hypertrophic cardiomyopathy affects the most. And when you take a look at this heart, one thing you just have to take my word for it is that those walls that are kind of surrounding that black area, which is blood basically, are not very thick. This is a very healthy heart that looks very good. Now, when you look at this heart, as you can see, that these walls look much thicker on that left ventricle side. And that's where hypertrophic cardiomyopathy happens. And so what happens is the heart gets very thick, it gets a little stiff, so the heart isn't able to fill blood as much. And it's hard to see on this picture, but with the thickened heart muscle, what ends up happening is that you can have obstruction of blood from the left ventricle to the main blood vessel, the aorta, which ends up going to the rest of your body, the brain, and the organs. And so when people say, I have obstructive hypertrophic cardiomyopathy, that's what they're describing Mr. Pitts did not have obstructive hypertrophic cardiomyopathy. He kind of had what we call non-obstructive hypertrophic cardiomyopathy, but both conditions are still at risk for sudden cardiac death with ventricular arrhythmias. And certain physiology factors play into that. I think Mr. Pitt's septum was very, very thick. Sometimes these septums can get up to 3 to 4 centimeters. Normal is around 0.8 centimeters. And your heart's not a very huge organ, so you can imagine 4 centimeters versus 0.8 centimeters is a huge difference. And the larger it is, the more at risk you are for adverse events.
So Brian was that 3 to 4% who needed a transplant. I want to bring in Nicole to talk to us about the Midwest Transplant Network and what is your role, because it starts with you.
Right, so we serve as the organ procurement organization for the state of Kansas and the western 2/3 of Missouri. And really, we're responsible for the donation side and working with our donor families, education. So when you say it starts with us, that really is, we meet with the donor families, work through authorization with those families, and then we also begin taking care of the donor patient. At the point the authorization happens, we are the ones that do the testing. We have a lab right here in Kansas City and Westwood that is responsible for doing all the different type of lab testing that's important to making sure that the gift is placed with the right recipient who's not going to go into rejection and has all of the different matches. And then from there, we work with the transplant centers. We make the offers based off of the national waiting list. And then that all varies by how long the organ can be out of the body for transport. All of those different pieces come into place, and our team does that. And then my role specifically then comes in helping with the education in our community. So we're really involved in making sure that our community, as Brian said in his interview, everybody should be a registered donor. And so my role really is to help people understand the importance of that, to help people meet people like Brian. He's one of the 3% in so many ways. And then also working with our donor families. We care for our donor families as long as they want to be a part of our system through grief support, through our ambassador program. So we really have the full spectrum on the donor side.
And Dr. Shaw, you know this, but anytime we have, whether it be liver or kidney or heart, anytime our doctors and surgeons come in here, they always talk about all the behind the scenes work that goes on, from the coordinators to the relationships that are built with those recipients, of course, starting with Midwest Transplant as well. So it's a team effort that starts way before the surgeons step in and do their job. So tell us about your relationship from the health system standpoint and how you're receiving the heart and eventually be placed into patients like Brian.
Yeah, to echo Nicole's point, I mean, heart transplantation, it's a very coordinated dance. There's so many different parts that end up all working really, really well together because communication is paramount. And with MTN and the Midwest Transplant Network and with our site, I really think that we have great communication. And so, like Nicole said, basically, unfortunately, with every transplant, obviously something tragic has to happen. And that's unfortunately the sad truth of transplant medicine. But with that, those certain donors allow us to have that gift to help save multiple lives, and I think that's really, really important. And I think that's really important when talking to donor families, that this really is a gift, and what we try to do is try to find how the best stewards of that organ. And so what we do is once this patient gets on the transplant list, we try to see if they're a good match. And that's based on so many different factors. That's based on the size of the donor, the blood type of the donor. Is it a good immune match? Because again, we want to avoid rejection. How far is that heart? There's a lot of different aspects that come to. And so as a cardiologist, I'll get that offer and we'll have to review that data, in real time very quickly, because these are time-sensitive decisions to make. And we try to see if it's a good match for our recipient. And if we say that, yes, it's a good match, then we go ahead, let our coordinators know, let MTN know, and the OPO know, and then we work on coordination of how to bring all the organ, sites, all the transplant sites together at the right time, because it's not just the heart that's being transplanted, it's the liver, it's the kidney, it's the lungs. How do you get 5 different teams from 5 different hospitals to come together at one time? There's a lot of organization, and I think that, kudos to your guys' organization to help make a lot of that happen. But it's amazing how it happens, and it always works out.
It always works out. You just make it happen. It is that beautiful dance.
It is. A dance is the perfect way to put it too, right? It's just incredible.
And speaking of timing, everything perfect timing. And Brian's transplant happened in the middle of the night. We know this is a 24-hour operation. Transplant never stops. What is that like to coordinate something at all hours? of the day and night.
Yeah, but it always happens at night.
Of course it does.
Even though it's 24 hours, it's in the end. I always get the calls at 2 or 3 a.m.
Yep.
They just know that I'm on call and they have to call. But it's what we do, right? It's a 24-hour, 7 days a week. These are very, very sick patients that we're helping, and these are time-sensitive things. If we don't get the right heart at the right time, then we're leading. That could lead to terrible outcomes for our patients. And so, happy to take those calls. And if they happen at 3 a.m., if they happen at
they interrupt your beauty sleep, you're okay, right?
Yeah, it's okay.
It's okay. You got it.
Yes.
You got this. So I want to talk about the numbers that Brian was mentioning earlier, the 2 to the 4 to the 0. His status changed from level 4 to level 2. What does that status represent?
Yeah, so the UNOS, which is United Network of Organ Sharing, has for heart transplantations has a status listing for patients who are awaiting heart transplantation. And the reason is that there's different levels of patients waiting for heart transplantation. Patients could be at home, relatively stable, maybe on an IV medicine. There could be patients who are on complete cardiopulmonary bypass. And the status list system tries to organize patients in levels of acuity. Who is at the highest risk of dying or having a high mortality in the immediate future. Status 1 being the sickest patients, then going down to 2, 3, 4, all the way down to 6. Actually down to 7, but 6 is where we're actually actively looking for organs. So for Brian, he started hypertrophic cardiomyopathy itself gives you a status 4. But once you start having malignant ventricular arrhythmias, how Brian was having, then that puts him, he was at a much higher risk of increased mortality at that time. And so because of his ventricular arrhythmias and him having so much VT, recently when he was being evaluated for heart transplant, we upgraded him from a status 4 to a status 2 because we knew that he needed that heart so much faster because his heart's not going to tolerate going back into ventricular tachycardia as often as it was happening. And so that allows him to go higher on the list because he medically needed the heart, and then that allowed us to get a heart. He still had to wait a long time, as he mentioned, but we were able to still get a heart for him quickly enough to help save his life.
Constantly monitoring.
Yeah.
Nicole, another part of your job, and it can be a really big moment, is connecting donor families with recipients and their families. Tell us what goes into that.
So that's it's such a beautiful thing, and it's a unique thing. It's not something that happens for everybody, and that's both on the donor side, the donor family side, and the recipient side. We look at everybody's going through their own journey, and so we have a process through MTN, and most OPOs have that process, and we work very closely with the hospitals and the transplant teams, where once somebody is ready, so once Brian is ready, he can write his letter. I know he's been working on his letter, but he can write, and then the families have the opportunity, they can do it anonymously. So a family may read the letter and choose to anonymously write back and say thank you. They can at some point decide, I'm ready and I want to meet, and then we help facilitate that as well. As far as release of information, there's all sorts of things that have to be signed. But I think what's really important, and one of the conversations I have a lot, our ambassador team, I have about 100 volunteers across our service area, and a lot of the conversation we have is around, for both donor families and recipients, is not to expect that you're going to hear back, but to expect that it's part of your journey to write that letter, and if that's what you're called to do, to write that letter. And so yeah, it's just it's more of the dance, right? We go back to all of this is, and you have donor hero families who it might take 15, 20 years before they're ready, but then they do, and they're ready. And the same thing on the recipient side. I know of a recipient who, it was 29 years. Wow. And finally their family was ready to make that connection. So it's just knowing that the writing is part of that process for so many, and you just kind of go with it. And when it works, it's incredible. It's absolutely incredible.
Brian, how's that letter writing going?
I actually completed it, I think, last week, and we forwarded it to MTN, and they sent it on to the family. It was a long write. It was only about a page, but I rewrote it and read it, and a lot of soul searching, a lot of tears. But I think finally it conveyed my feelings for my donor and the connection I have, and that really, at the very least, that I could get a name and maybe a little information about my hero. I just like to know those things.
Your hero. I like it. I like how you call your donor your hero. Brian, another part of your journey, though, is also being an organ ambassador. You drive around in this green Jeep, and you make it known that you've gone from, a survivor, a recipient, and now you're sharing your message with the rest of the world. Why has that been so important to you?
So I've been passionate about it from really the get-go. Everything. I don't have a shirt on today, but I tell you, my mouse pad, and my hat, it's kind of my wardrobe on the regular. When I was in the hospital during recovery, and I was walking laps around the unit in ICU, healing, a gentleman walked up to me, and said, "Hey, what are you in for?" And I said, "Well, I just had a heart transplant about 5 days ago, and I'm going to go home tomorrow, I think." And he was dumbfounded. His name was Anthony. We were great friends still today. We talk quite a bit. And he had a similar medical condition. He was on an assisted device that was helping his heartbeat, and he had to touch me. He had to put his hands on me and say, "You look amazing. You just had a heart transplant 5 days ago. You're going home? What?" And he was so inspired and so moved to see how well I was doing, that relationship built. And I said, I really inspired this guy. And so it became very important to me to continue that inspiration with other people. I've connected with at least a couple of donors or a couple of recipients through an organization that does that, the Gift of Life Network. But just through Facebook, just talking to people on these forums and transplant pages that they're scared, they need help, they want to talk to somebody, they have questions. The medical community as a whole, they do their very best to try to convey as much information as they can about the medical side of the situation that they're facing. But a lot, it's so much to take in that somewhere they have to kind of stop, because it is a flood of information. Your head is spinning, and it's happening so fast. So a lot of the kind of human side that takes care of those questions. These people are kind of terrified. They're thinking about end of life scenarios. You plan for the best or hope for the best, but plan for the worst. So some of those conversations to have with these people are, this is kind of what you need to do to get your things in order and prepare for this massive life-changing surgery.
They need people like you right there by their side. Yeah, you're just beginning. It didn't just end with the transplant. Your mission is completely just beginning. Be sure to ask your questions for anyone on our panel today. You can use the chat on YouTube, Facebook. You can tweet us, email us at the Medical News Network. That info is there on your screen. Let's get a quick check of our COVID count with Dr. Hawkinson. Good morning.
Hi. Good.
Hey.
It's going well, and certainly the active infections are doing well as well. So 25 total, just 10 active infections, unfortunately 3 in the ICU and 0 on the ventilator. So
Dr. Hawkinson, question. So last month, the health system stopped requiring face masks for staff and visitors in most of the areas here at our place. We're seeing people's faces again, which is nice when we walk down the halls. But one viewer, Jason, he emailed us a few good questions I wanted to ask you. First, have we noticed any change in infection rates once the masks came down?
Yeah, here in the health system, again, masking is not required. A lot of providers still use masks. I know I certainly do, especially in patient-to-patient encounters. But we have not seen any increase or really any cases that we know of hospital-acquired COVID-19 infections from a patient to a staff or a staff to a patient. So that is overall good news.
So how do we determine, another question from him is, how do we determine if COVID gets transmitted from staff to patients? Any way of telling?
Yeah, so absolutely. With infection prevention and control, for which I'm medical director and work with a great team, we have systems set in place to look at hospital-acquired infections, not just COVID, but a number of different infections as well. We have that same system set up for COVID. If we do find out that somebody is, starting to have new symptoms, they are tested while in the hospital, and now they are positive, when before they had no symptoms whatsoever. We then do an investigation and look at exposures, as well as who from the health system was working with that patient. So there is an investigative process to go along with that.
Okay, Jason has one more question. I think I know what you're going to say, but I'm going to let you give the official answer. So if fewer people are wearing masks and the infection rates are staying low, does that mean that the medical masks weren't useful in the first place.
No, that's absolutely not true. And in fact, we have great peer-reviewed articles in very well-respected journals, such as the New England Journal of Medicine. You know, there was that large study from Bangladesh that was a randomized control study that looked at groups of people who were wearing masks versus not wearing masks, and it showed that those that were wearing masks had improved infection and hospitalization rates. There's also been recent other publications looking at masking in schools, where certain school districts were masking and certain were not. And there was also the study showing that even people who were just wearing a mask when other people around them weren't did help reduce infection. So we have very good peer-reviewed studies to support the use of masks to help protect against infection as an individual, but also in the community. Again, and that's why we always say it is always safe and good to wear a mask. If you are at high risk for infection and you're going to an area or going to be in a situation where you feel is high risk, it's always okay to wear a mask. I know some people are still wearing masks on airplane flights as well and travel. So I think it's always good, but we do have very good evidence to support the fact that masking does work. I think right now we are just dealing with a set of different factors than we were 2.5 years ago. Number one, personal immunity. So either that's through vaccination, which is the safest, but also infection and reinfection. And from that personal immunity, we also have and understand that there is now community-wide immunity. So the other part to that is we are believing now SARS-CoV-2 is getting into more of a seasonal pattern, while not still as strict as, say, RSV or influenza, which really has significantly low circulation during the warmer months. We know there's still going to be some circulation of SARS-CoV-2, probably a little bit more than RSV and influenza, but we are getting probably into that pattern of the respiratory viral season circulation, where we'll see higher circulation, and this is what we anticipate, higher circulation in those colder months with the other respiratory viruses as well.
That's exactly what I was going to say.
I thought you were. Well, we talked about that, and
Right.
I copied your answer.
You did good. You did good. Thank you. All right, any reporters with us today? Let's get to a few community questions here. And Yen Liang wants to know, do patients who have received heart transplant need to take anti-rejection medications for a lifetime?
Yes,
Yes,
they
okay.
do. Again, the risk of rejection is the highest in that first year, and so the level of immunosuppression is higher in that first year. But as Brian knows, as we go further, we decrease the amount of immunosuppression. But for lifelong, they are on low levels of immunosuppression to prevent late rejection.
Lynn wants to know, are there more organ donors today than in the past? Where are we at?
So every year we're seeing more people join the Organ, Eye, and Tissue Donor Registry saying yes, and that's a lot of what my work is, specifically with MTN. But that doesn't negate the fact that there's still 100,000 people waiting for those life-saving organs, and that 17 people a day will die waiting for that transplant. So while we do see an increase in those who are registering and more organs as science is evolving, right? And that's it's almost crazy in 2023 that we're talking still about the evolution and the change and how much better we're getting every single day. There's still a high need, but yeah, absolutely, we're definitely seeing higher numbers. We actually recovered more organ donors last month than we had in any other month previously in our 50-year history. So,
all good news, but still work to do.
Absolutely.
Let's get our takeaways today.
It's
And
the
Nicole,
Jeep.
start with you. What do you what's that? Go ahead, Brian.
I said it's the Jeep driving around Kansas City.
It's the Jeep effect. I'm telling you.
Yeah.
It is.
Yeah. I tell everybody, I tell all my friends, I said you need to go to the registry and sign up. It's not good enough just to be on your driver's license. Just go to the website.
Exactly. Spray paint, gas up and spray paint your truck. I love it. What do you want folks to take away from our talk today, Nicole?
I think really it's important to make sure you understand your why for saying yes, that you're having conversations with your families. A lot of times we say yes at the DMV, we join the registry through the website. ShareLifeMidwest.com is the local registry, so that's the Kansas and Missouri registry. But really then it's the next step is the conversation and letting your family know and letting your community know. Not only does that make it easier if, heaven forbid, that's a conversation that they have to have. They meet an MTN staff member to talk about organ donation, but it also starts a ripple effect of acceptance and makes it easy for people to understand and want to join. Brian started advocating 3 weeks after his donation. He was at our Donate Life Legacy Walk last June, and he probably shouldn't have been there, but he was there. And it's stories like Brian's that I think I want everybody to hear and to know, because not only is it stories like Brian's that are, the face of donation and the life-saving gift, but it's also the healing journey that so many of our donor families and our donor hero families have gone through, and that they accept as part of their story, right? It's their family's legacy. And so there's just so many things, but really at the end of the day, it's understanding your why, having that conversation, and if you have questions, not being afraid to ask. Reach out to us. That's, I go out every day and talk to community members. I have one-on-one conversations, and so the information is there, and we just want people to make sure they're accessing it, and then hopefully saying yes and becoming a registered organ, eye, and tissue donor. 133,000 lives is what MTN impacted last year through organs, eyes, and tissue. That's incredible.
It is incredible. Thanks for the work that you do.
Yeah.
Appreciate it. Dr. Shaw.
No, I think, Brian, always great to see you, and I'm glad that you're doing really, really well. I know we were talking a lot about heart transplantation, but I don't want to go back and talk about hypertrophic cardiomyopathy, which again is a genetic condition. And I think I'm really proud to be at KU under the leadership of Dr. Berenbaum, because he really helped KU become a center of excellence for hypertrophic cardiomyopathy, which allows us to treat patients with hypertrophic cardiomyopathy and have all the tools, from medicines and to surgery to even minimally invasive procedures as well. So we have all the tools here to really help tailor the treatment towards each patient with hypertrophic cardiomyopathy. And I think one aspect of it is genetic testing. That if you have hypertrophic cardiomyopathy, it's very imperative to ensure that your loved ones, your children, your brothers, sisters, your parents get tested for hypertrophic cardiomyopathy, because there's a 50% chance that they're going to have hypertrophic cardiomyopathy as well if they inherit the gene. And so that requires, cascade screening, genetic testing, genetic counseling, all things that we can offer here at the University of Kansas. So I'm proud to be one of the doctors that is part of the hypertrophic cardiomyopathy clinic, and again, give a lot of credit to Dr. Berenbaum. Mr. Pitts is a cardiologist who referred him to our center because he's been a huge proponent and a huge leader to make this happen.
All right, you're coming back to talk more about that specialized clinic, okay?
Yes.
You walked right into that one. All right, Dr. Hawkinson, final takeaway.
Yeah, another great story, and just, again, such great teams here at the health system. Just remember, for the most part, COVID-19 is really not affecting most of us. We have moved past it, but also remember there are those populations that significantly have to continue to have a concern about it, and just go about your day and understand that there continue to be, people like our patient who we see who continue to be immune suppressed, who can be significantly affected by COVID-19. So be up to date with your vaccines. We know new vaccine recommendations came out, and again, it's always okay and safe to wear a mask.
Always. Brian, I'm going to let you wrap us up. Tell us what the takeaway today is.
Oh my gosh. Get out there and have the conversation. Like Nicole said, it's important to talk to your family members, your friends, and get them to sign up as registered donors, and let your family members know what your wishes are. God forbid something should happen to you. It's somebody out there just like you that saved my life.
All right. Thank you so much for sharing your story, and just get out there, keep driving, and be safe, okay? We appreciate you, Brian. Stay in touch. Oh my gosh, Alexis, how
He's
fun.
incredible.
Isn't he great? I know.
I want to ride in the green Jeep.
I totally want to ride in the green Jeep. I have to see the green Jeep.
We'll have to ask him.
So All Things Heart's coming up at 10 a.m. What you got coming up for us?
You're going to meet a really incredible woman named Julie. And the Topeka woman was living with this horrible pain that she thought was from an old back injury.
I literally felt like I was dying from the inside out.
Finally, she wound up here at the University of Kansas Health System, where she met with a vascular surgeon who diagnosed her with something far more serious than a back injury. Half of Julie's body wasn't getting the blood it needed. So at 10 a.m. on All Things Heart, Julie joins us with her incredible surgeon, Dr. Kara Hessel, who explains the problem and the surgery she performed on Julie that fixed it. The results are incredible. Wait till you see Julie now. That's coming up at 10 a.m. on All Things Heart. So bring your questions and your comments.
Yeah, Julie French, she's another great patient as well. Looking forward to seeing her and seeing how well she's doing. Alexis, thank you. And thanks to all of our guests today and our viewers. We'll see you back here tomorrow at 8. Coming up tomorrow on the Morning Medical Update. We know cancer prevention is critical, and so is knocking that cancer out if it strikes you or someone you love. I'm Jessica Lovell on the next Morning Medical Update. Friday at 8, fighting cancer while living the life you are meant to live.
Subscribe to our Morning Medical Update and Open Mics with Dr. Stites podcast. Now, everywhere podcasts are available.